Ladies and gentlemen, it's a pleasure for me to give a short presentation on uh, some of our research work in the past year. A couple of years ago, Greg and his colleagues invited us to write a review for Nature Review Cardiology. Here you see the change in the past about 30 years in the prevalence of hypertension across different age group. So you see in all age groups, the prevalence of hypertension increased substantially, even in very young people at the age of 15 to 24 years. So we have to try our best to fight against the disease and actually to control hypertension in as many people as possible. Here I would discuss three major issues. So you see here we have seasonal variation in blood pressure and combination therapy, and finally the use of angiotensin receptor and neprilysis inhibitors in management of hypertension in China. And you see here blood pressure actually changes over season, and if you look at daytime blood pressure, actually you see a drop in hot summer and increase in cold winter. But when you perform 24-hour blood pressure monitoring, actually you see a very different scenario. Here you see actually higher blood pressure at night during summer, but lower blood pressure at night during winter. So if you only measure blood pressure in the daytime in the clinic, then you probably lose a lot of information on blood pressure level, especially during sleeping night hours. Then we further investigated the risk of nighttime blood pressure in different seasons. Here you see the steep slope actually was observed in summer. You see a higher blood pressure at night during summertime, and you see also a stronger association between nighttime blood pressure and various measures of target organ damage, here including albumin to creatinine ratio, carotid femoral pulse velocity, and left ventricular mass index. So all these three measures of target organ damage actually had closer association with nighttime blood pressure during summer time. And we also further look at treatment effect according to the months of treatment commencement. Here you see if you start treatment during summer, then actually you see a smaller blood pressure reductions at 8 or 12 weeks of treatment. And if you start later, for instance, in autumn and winter, and you see 5 to 10 millimeter of mercury greater reductions for systolic and diastolic blood pressure, if you compare with those patients who started treatment during hot summer months. Then we also look at between season blood pressure differences for, you see here, for 8-week and 12-week treatment for both systolic and diastolic blood pressure. Actually, you see a greater blood pressure reduction. And if you start treatment during autumn and winter, then spring and summer. That's probably because during the cold or less warm months, and you more likely increase your treatment intensity, and you achieve much greater blood pressure reductions. And if you look at the goal attainment rate, and you see uh, very similar results, regardless whether you only look at systolic or diastolic blood pressure, or you look at both blood pressure components, and you see a different control rate of hypertension if you compare the two different the two different season periods. And then we also look at 24-hour blood pressure profile by season. So you see during winter, autumn and winter, you see a greater blood pressure reductions during sleeping hours. Again, probably because you more likely increase your treatment intensity, both in terms of number of drugs or the dose of drugs. So you see a greater drop over sleeping hours in winter and autumn than in spring and summer. So actually, it means that in spring and summer, you would have higher systolic and diastolic blood pressure during sleeping nighttime hours. And again, here, if we look at the mean change in daytime and nighttime blood pressure by season, you see a contrasting results for these two different time periods. You see a greater blood pressure reductions during nighttime for the cold autumn and winter seasons, but you see a very different results in spring and summer. Here we look at nighttime dipping. So we know that non-dippers tend to have a higher risk of cardiovascular events. Then if you treat more intensively in winter, then you would have a reduced prevalence of non-dipping, and you would see a different results in spring and summer. You would have a lot of patients who even changed to non-dipping status in those patients who started treatment during spring and summer. So season is a very complicated factor for the management of hypertension. You always tend to decrease your treatment during hot summer and increase your treatment during winter. But actually, if you perform 24-hour blood pressure monitoring, you probably should also change your treatment, then also control the nighttime blood pressure. And the second part is about combination therapy, because we now recommend the use of combination therapy in many patients with hypertension. Certainly for those patients with stage 2 and 3 hypertension, and even for many of those people with stage 1 hypertension, but with inadequate blood pressure control on monotherapy, we also need to start combination therapy as early as possible. And here you see we did a randomized controlled trial to compare two different approaches for dual combination therapy, because current guidelines recommend two different strategies: either combine amlodipine as a calcium channel blocker with benazepril as ACE inhibitor, or you will combine ACE inhibitor with hydrochlorothiazide, which is a diuretic. So most of the guidelines recommend the use of these two combinations, but the actually may have different blood pressure lowering effects. That's why we did this comparative study to look at blood pressure lowering effects in patients with monotherapy uncontrolled hypertension. You see they had systolic and diastolic blood pressure over 140 and 90 in spite of monotherapy treatment. Then you uptitrate to combination therapy, then you look at the blood pressure results. So here you see we perform 24-hour blood pressure and home blood pressure measurement in all randomized patients. And finally, when we compare the primary endpoint, which is 24-hour systolic blood pressure reductions at 24 weeks of treatment, and we didn't see a significant difference between the two combinations, but for the secondary endpoint, 24-hour diastolic and several other blood pressure components, we did see some significant differences for 24-hour diastolic blood pressure and daytime diastolic blood pressure, but not nighttime blood pressures. And finally, here I would show a trial we did in the past few years. We published the study results recently. You see, we actually investigated a new neprilysin, angiotensin receptor neprilysin inhibitor, sacubitril alisatan, with olmesartan as an angiotensin receptor blocker. So you see here we have two different dosages of sacubitril alisatan and one dose of olmesartan. So when you look at the results for clinic blood pressure measurement, on the left hand you see systolic blood pressure, on the right hand as diastolic blood pressure. You see for both systolic and diastolic blood pressure, the higher dosage of sacubitril alisatan significantly reduced blood pressure in comparison with olmesartan 20 milligrams monotherapy. But when we look at the lower dose of sacubitril alisatan, which is 240 milligrams, the difference was a significant difference was only achieved for systolic blood pressure, but not for diastolic blood pressure. When we further look at 24-hour blood pressure lowering effect, here you see on the left hand 24-hour, in the middle daytime, on the right hand nighttime blood pressure. Here you see always a significant for both low dose and high dose of sacubitril alisatan in comparison with olmesartan, and for both systolic and diastolic blood pressure. But when you look at daytime and nighttime blood pressure separately, then you see even greater blood pressure reductions over these nighttime sleeping hours for both systolic and diastolic blood pressure. Here, actually, you see a very significant results. The difference was 2.6 for the lower dose and 5.7 for the higher dose. And we also did the long-term blood pressure lowering effect and safety results. You see over 52 hours, if you continuously use this drug, then you see blood pressure remained controlled at the 130 over 80 at 2 or 3 millimeter of mercury. And over these three different periods, in the beginning, that's the double-blind period, then open label titration, then finally open label titration, prolonged treatment, and you see always very well-controlled blood pressure. And finally, again, I would show you the goal we set up a few years ago. We tried to control blood pressure in the Chinese population in 50% of those hypertensive patients. Thank you. Thank you very much.